Thank you very much for the invitation. It's an honor to join this great meeting, and I joined a lot of the sessions this morning, so fantastic presentations this morning from great speakers. So we are shifting now the topic to deep venous, and yeah, it's my pleasure to discuss with you the rationale for venous stent selection and implantation, to stent or not to stent. Here are my disclosures. So of course, the patient is always in our focus. This not only counts for the superficial vein system, it especially counts for the venous system. And we always have to raise the question, should the patient be treated? Should we treat the patient from a technical point of view? Can the patient be treated? So therefore, I must say we should follow the rule, don't treat the lesion, treat the patients. And we should always consider the findings on non-invasive diagnostic like CTV, MRV, duplex, and to take this in consideration to answer the question, can we treat the patient? Of course, a lot of technical issues are coming along when we want to treat, especially chronic deep venous disease like post-thrombotic syndrome. And here the most important question is, can the patient be stented? So important technical questions are, is the landing zone optimal for this? Have we good inflow from the profunda vein, from the femoral vein? Or do we need to even organize a combination therapy of endovascular plus endophlebectomy therapy? So can the patient be stented is a crucial question. And these questions are divided in much more complex questions. So most important topics are here, is the central landing zone sufficient? Is the IVC patent? So do we have good outflow? Does the disease involve the IVC? Then we definitely need to consider a total different endovascular approach than just treating a Maid-Thurner or an external iliac vein or common femoral vein. Is the peripheral landing zone okay? Do we have an involvement of the common femoral vein? Is there a good landing zone for our distal stent? Can we land the stent just proximal to profunda to really get profunda inflow and do not harm profunda inflow? So a lot of questions, technical questions, which need to be answered before we start with the endovascular process. And here's a typical case report, which I would like you at the beginning of my presentation, which shows the complexities. This is a 20-year-old female patient, very active, non-obese. This patient was treated in the north of Germany. She was treated because of an acute ilofemoral DVT Maid-Thurner syndrome associated on the 6th November 2020. They performed an open surgery on the 11th November with thrombectomy and wall stent implantation. The length of the wall stent 90 millimeter. Reocclusion, unfortunately, on the 14th. Again, open surgery, AV fistula was performed. Reocclusion, unfortunately, again on the 19th. So they decided by this time to do a conservative approach. The patient still very painful, swelling, very much claudication. So then they decided to send this patient to our center on the 14th of December. She had massive swollen leg and venous claudication. Everything was reoccluded, including the profunda vein, including the femoral vein. And of course, the AV fissure was also. So we decided to perform a very distal approach in this patient and to perform another attempt, not from the groin, not from the femoral vein. We started from the tibial vein. This is our standard approach actually for very distal thrombosis puncturing into the anterotip vein here, in this case with an 8 French Terumo access sheet. And what we found here was a very bad inflow. So the issue why this patient reoccluded by 2 times was because of very bad inflow. And here you see the real challenge. You always need to assess the inflow. You always need to assess, is it okay to stent? Otherwise you fail, the stent will be occluded. So we started then to perform thrombectomy using the JEDI system, thrombectomy system, which was recently launched and now acquired by Abbott. And you can see that we treated this patient with thrombectomy, and years after 2 thrombectomy attempts here already some inflow. And then, of course, we cleaned also the already implanted wall stent, still having here some issues in the external iliac vein. But in the last pictures, you could already see the inflow was much better, and the outflow was okay. The wall stent was good after thrombectomy. And these are the final pictures here of our endovascular reintervention. And because we cleaned the inflow, we opened the inflow, we opened the profunda vein, this stayed patent now. So that means a lot of technical situations, and if you see something like that, don't stent because inflow is not sufficient. So that means stenting needs to be definitely decided on many aspects, and inflow is one of the most important aspects. So blood flow is something we really have to go back to the basics, physical basics. If we have bad inflow, low pressure, low velocity, we cannot stent because we will fail. We will lose the stent within hours or days with reocclusion. So flow is one of the most important aspects. So there are a lot of techniques now available how we can improve it. From an endovascular approach, flow using crossover attempts. We can do dual wire access. We can use thrombectomy. You can use cutting balloons. We can use stenting of the profile. But we have to do it, otherwise we fail and see really negative outcomes if we see stents very fast occluded after days. And this is something which also is important if the inflow is on a chronic side not good, like this patient here, we see very tight restenosis after a couple of months because the inflow only can open the middle part of the stent here to make it patent. There was no chance of really getting enough flow to the whole stent area, so just the central line of the stent stayed patent. So this is the funnel principle. So therefore, assess always the inflow from the profunda and the femoral vein. Otherwise, the stent will occlude over time here, as I call it, a chronic funnel principle, restenosis of the stent. So there are a lot of complex questions, therefore, of course, we do not have the sufficient answer yet. What is appropriate inflow? What is the threshold for endophlebectomy over fistula? If inflow is bad, do we need to implant smaller stents? These are the questions which are now, hopefully very soon, will be analyzed in trials. But to avoid these kind of complexities from the beginning on, we should probably accept conditions. So we need to check on indication, as I just mentioned, always check on the patient first. Plan your case, meaning inflow. Use current stent, and I will come to the stent situation in a moment. Check for in and outflow as mentioned, and be prepared always for complications, and be prepared for bailout like endophlebectomy or labial fistula. Let's come to the stents and the stent situation. The stent market is rising, and you see the global revenue for the next years of stents. The venous stent market will explode. This is good, this is bad. I see more May-Thurner syndrome patients treated, which takes a little bit concern. I think treating just May-Thurner patients with a little bit swollen leg. We have to see if this is really a good attempt. This will be answered over time. Unfortunately, the more cases are done, the more stents are implanted, we see complication. And we saw complications in the last 1-2 years, which were reviewed. And these are cases like this one here, which was published from different colleagues. Right heart migration of the stent because the stent was too small, the stent was not long enough, and migration happened. And this needs to be avoided, definitely. So therefore, we definitely need to think about adequate training to prevent such complications. Stephen Black and his team performed a very nice review of these complications, and they summarize these data suggest that the migration is more likely to occur with short, small stents, with the combination the most common. This means don't use short stents, small stents for treatment of May-Thurner syndrome without any post-thrombotic changes. There's a high risk of migration, and this definitely needs to be avoided. There are a lot of stents now on the market. We have in Europe now the 14th stent, dedicated venous stent on the market. The Vici stent was recalled because of the migration issue. The Novo stent came back to the market just a couple of weeks ago. So this is very optimistical. The new stent also just entered the market. This is the Vesper stent from Philips. So we need to see if this stent performs well in the studies which are now going on. So therefore, it's important to talk about stents and the different stent attributes. We know that in general, venous stents are a compromise of strength and flexibility, but the general rules for venous obstruction, crush resistance, absolute. We saw a lot of these pictures here in different stent designs like gap formation, kinking, push scaling. The question, of course, is, has this any clinical impact? Is this important when we choose a stent? We don't know at this moment. Probably we know it maybe for very distal implantation like below the ligament or on the common femoral, but in general, these are just bench tests. And therefore, we do not know if we can really consider this as a problem in patient and definitely need to find that out. What we definitely know is that some stents have issues like a wall stent, which is not fixated proximal. This stent within the May-Thurner syndrome is compressed because it's not fixated proximal towards the IVC. So you see the reduction of diameter of a 40 millimeter stent down to 10 millimeter. So this patient will still suffering from symptoms because the stent won't fix the May-Thurner syndrome here because it is compressed. And if the stent is compressed, then we are unfortunately facing reocclusions. So aspect ratio is here the important IVUS analysis we have to perform. Aspect ratio of 2 impacts patency. This was already proven by Lowell Kapniks a couple of years ago from the Vici trial. So don't allow a stent to be compressed. An aspect ratio of 2 is a high risk of restenosis. So check for a dedicated stent which really can stand the external compression within the May-Thurner syndrome. This is the publication from first of all Lowell Kapnik and myself, which we published on that. So you see here on the lower part the aspect ratio. Aspect ratio of 2 means a significant increase of the gradient, pressure gradient within the stent. You see a reduction significantly of the flow factor with an aspect ratio of 2 and an area factor. And these are the technical reasons why stents will reocclude. Therefore, there's not a perfect venous stent on the market for the whole system. This is definitely a dream. These stents have different physical behavior. We need to know them so that we choose the correct stent for the correct indication. And here you see the difference in terms of crush resistance for a stent. There's a significant difference between, for example, Optimate stent and the Cook-Silver venous stent in terms of crush resistance. And if you use a weak stent in a May-Thurner syndrome, you will see what just happened in the wall stent I showed you. This stent will be crushed and this stent will be restenosed or retrombosed, and the patient will come back very soon with a rethrombosis and symptoms. So therefore, choose the correct stent with the correct crush resistance for each indication. Therefore, we have to raise the question, is it only radial force, positioning, and flexibility, which is always analyzed in studies to read judge on the stent? I personally believe not. There are a lot of more factors which need to be considered in trials, a registry, to answer if the stent is sufficient for that or that indication. So we need real-world long-term data. We need definitely good visible stents, because a lot of stents are implanted with C-arms just, and this means these stents need to be visualized very well. Below the ligament, different story. I will come to this in a second. And of course, we have to talk about costs and of course, predictable landing zone, ensuring a minimal foreshortening of stents. The IDE trials are helpful to get first ideas of the stents, but be careful to compare directly to these IDE trials. The stent length zones of these stents are different. So the patency is not be able to be directly compared because of the different standard lengths. It is not fair to compare a silver stent with an arbor stent because the standard length situation is different, so the patency can't be directly compared. And also the outcome data of these stents are very differently assessed, as you can see on the right side. Primary endpoints were very different in these trials, so also very important to compare apples with apples based on these IDE trials. Therefore, I really appreciate large registries like this here, 1,008 patients included in 14 studies recently published, primary patency at 36 months, 66.3%. I think that is realistic. This is something we can take for discussion. It is a dream to have open patent or patency situation more than 90% after 3 years. That is probably not realistic. Below the ligament, we are facing a lot of facts, and this is my last topic here. Below the ligament is a different story. We know about stent fractures below the ligament, already published in 2017 from the London group. As you can see here, primary patency above or cross the ligament, significant difference, for example, for wall stent or 19 venous stent. So below the ligament, different roads. And also Niels Cooper showed this in 2018. The stent below the ligament is definitely high risk for restenosis. So we need dedicated stents for below the ligament. Woven nitinol seems to play here the best role, like blue flow venous stent. This is a good option. We just recently published on that with a direct comparison between a laser cut nitinol stent and woven nitinol stent for the indication of below the ligament stenting, and we found that there is a significant difference between laser cut nitinol stent and woven stent in terms of patency. So probably woven stenting, like the superior stent below the ligament, seems to be an adequate answer for that area, even that secondary patency was not different. There are a lot of stents now coming to the market, like Beyond Stent, just showing here the first outcome data from our Arnsberg Venous Registry. Very good outcome after 6 months, but it's too early to really draw a conclusion. We did, of course, also for this stent a long-term patency analysis, which we will hopefully publish next year. New stent developments coming from Gore. It looks like a Tigris stent. This is now open for an IDE trial, will be analyzed in Europe and US. IVC and iliac lesions will be treated within these trials. Very interesting to see. And of course, the Vesper stent, first data will be shown next year at Chatham Cross for this hybrid stent. So another very interesting option for Maid-Turner with an extension part, which is very flexible. So in conclusion, dedicated venous stents are mandatory for treatment. Stenting is not the question. Stenting is a must if you decide to treat deep venous obstruction. But you have to check if the inflow is good, if the outflow is good. If this is not the case, then it will probably fail and reocclude whatever stent you will implant. So flow is the absolute important aspect. Dedicated venous stents are important. We will need more prospective data for the stents, especially from all-comers registries. Thank you very much.